All right, so we're going to look at pericardial disease today. Uh, in particular, we're going to look at acute pericarditis, pericardial effusion in depth, cardiac tamponade, and constrictive pericardial disease. So all the stuff that can affect the pericardium, we're going to look at those. All right, so acute pericarditis means that the pericardium is inflamed. And if you want to see severe pain, you see someone who have acute pericarditis because they have a severe sharp pain. The only comfort they usually get is when they sit up and lean forward. Okay. The causes for acute pericarditis could be idiopathic. You don't know the cause. It could be infectious, bacterial, viral, fungal. Patients with acute renal failure or even chronic renal failure can develop acute pericarditis. And then myocardial infarction, the so-called heart attack. Um, Also from malignancies such as breast or lung cancer, radiation therapy. So if someone have a malignancy in the chest, breast, lung, and they receive radiation treatment, that can cause an acute pericarditis. Trauma as well. Patients with collagen vascular disease such as lupus and rheumatoid arthritis can also develop acute pericarditis. And then there are some medications that can cause it, procainamide and hydralazine. So first, you have to know how to identify pericardial effusion on the echo. All exams is gonna have, you know, how do you identify pericardial effusion as opposed to say pleural effusion. Okay, so your parasternal long axis view is the view that will help you to make that distinction. So your right ventricle septum, LV cavity, posterior wall, and then down here you see something that you shouldn't see. Okay, so remember again, fluid is darker black. Okay, remember that this is your descending aorta right there, left atrium, mitral valve, aortic valve. Okay, so whenever you have any fluid which is black, which is anterior, okay, this is going anterior to the descending aorta. That's usually pericardial effusion. If the fluid is posterior, behind the descending aorta, then it's usually pleural. Okay. All right. So pericardial effusion, that is just fluid now. The same cause, idiopathic, we don't know, infectious, bacterial, viral, fungal, metabolic, such as renal failure and hypothyroidism, malignancy, breast, lung cancer, radiation, therapy, trauma. So if the patient was involved in a motor vehicle accident, a blunt, so the steering wheel hit them in the chest and you see fluid there, you have to assume it's blood. You have to assume it's blood. And that, if you see that it's blood, that's a surgical emergency. So someone who is involved in, trauma to the chest, and you do an echo, if you see fluid in the pericardial space, you have to assume it's blood and treat it as an emergency. So, of course, collagen vascular disease such as lupus, rheumatoid arthritis, and again, medication, procainamide, hydralazine, and minoxidil. So just straightforward pericardial effusion, signs and symptoms. A patient may not have any signs, okay? May not have any symptoms. However, for a large effusion, you'll see a low voltage ECG, if the fluid is large. And again, the patient may be asymptomatic. If the patient have acute pericarditis, then you can make that assessment on the 12 lead ECG. So with acute pericarditis, patient usually is in sinus tachycardia, heart rate above 100 beats per minute. they'll have diffuse ST segment elevation and what we call PR segment depression. And if the fluid is very large, they can have what we call electrical alternance. That is alternation, large and small complexes on the on your ECG. So there will be one QRS which is large, the next one is small, next one is large, and then the other is small. So we call that electrical alternance or electrical it's supposed to be alternance. So it's electrical alternance, alternating big and small complexes, QRS. Now, if the fluid is preventing proper filling of the left ventricle or the right ventricle, then the patient can develop what we call cardiac tamponade. So cardiac tamponade, it's usually a clinical syndrome. However, we can look at the echo and we talk about an echo tamponade. So you have to know what echo tamponade consists of, because usually patients will have echo tamponade and then they go on to clinical tamponade. Clinical tamponade will, the patient will die. So if you see tamponade in the echo lab, then you need to alert the physician so that they can do appropriate management. So with cardiac tamponade, you get hypotension. The blood pressure usually falls. When you listen to the heart, you have distant heart sounds, elevated neck veins, because since blood cannot get into the heart, the veins are going to be engorged with blood. So when you look at the neck veins, they'll be distended. Even though the patient's pressure is low, they have distended neck veins, shortness of breath, and then they pass out because the cardiac output is reduced, so they pass out. So what happens is, of course, the heart fills with blood in diastole, but if you have fluid that preventing the heart from filling, then it's going to quickly increase the filling pressures. So the pressures in the ventricle and also the atrium is going to be elevated, which is going to prevent blood from getting into the heart in diastole. So the neck veins are going to be elevated because blood cannot get into the ventricles. Blood cannot get into the ventricles, so the cardiac output is going to be reduced. The patient's going to be hypotensive. When you listen to the heart sounds, you're going to have distant heart sounds. So the subcostal view is one of the best views to assess pericardial effusion, because if it is generalized, circumscribed, so you can see it, because this is just outside of the left ventricle, goes towards the apex, and it comes all the way to the right ventricle and the right atrium. So this is generalized pericardial effusion. So the subcostal view is one of the best view to look for that. Okay, again, you can measure it, and you can when you report pericardial effusion, you can say small, moderate, large, but the clinical picture of tamponade, or the clinical picture of pericardial effusion, depends on how quickly the effusion forms. Because sometimes you'll have large pericardial effusion which doesn't really cause any compromise. And you can have a very small amount of effusion that will cause tamponade and death, because it forms very rapidly. It forms quickly. So the heart didn't have time to compensate. Okay, so if the fluid develops slowly, then the heart will compensate for the increase in volume and pressure. So you can measure it. So a small effusion, it's tiny, usually much less than 1 centimeter when you measure it. Uh, if the effusion is generalized, circumferential, and is 1 centimeter, we usually refer to that as a large effusion. And then anything in between, moderate. The effusion can also be loculated, it is just present in one area. So if the effusion is just in one area, we say that it's loculated, okay? And you can see that. When you have suspected tamponade, when you have any pericardial effusion, you should get your M mode, because the M mode is crucial, help you quite a bit. So you have your fluid, you put your cursor right there, and then you press your M mode button, and just analyze what's going on. So of course the chest wall the chest wall is right up here, and then this is actually RV wall right here. This is the RV wall, and then this is pericardial fluid. So it's pericardial fluid, and you see you get periodic indentation in the RV wall. So the RV wall collapses periodically. Then this is the RV cavity right here, RV cavity. Okay, just look up here and you can see the structures that you're crossing. So this is the RV cavity. This is the aortic wall, the aortic valve inside, and then this is your left atrium. Okay, a left atrial wall. So just look right there and see the structures that your cursor is crossing. But again, what you're looking for is the pericardial fluid, and you have periodic indentation in the RV wall. Is the definition for tamponade is RV or RA collapse, diastolic collapse of the RA or RV. That is the definition. Diastolic collapse of the right atrium or right ventricle. So we have this collapse that's occurring here. You have your ECG on top. Even if you didn't have an ECG on top, you could still determine if this is tamponade, yes or no, because you have your aortic valve right there. The aortic valve opens in systole, closes in diastole, opens in systole, closes in diastole, opens in systole, closes in diastole. So you see these collapses are occurring when the aortic valve is closed, aortic valve is closed, aortic valve is closed. So this is diastolic collapse of the RV, okay, which is tamponade. So this is a patient that you would call the physician and get treatment for the patient right away. Okay, so even if you didn't have your ECG on top, or if the ECG is not adequate, then just look at what's happening to the heart, and you know that this is systole, this is diastole, this is systole, diastole. So your M mode is very important to help you to determine tamponade, yes or no. So with cardiac tamponade, it is diastolic collapse of the right atrium and right ventricle. And if you look at the IVC will be large. You get the IVC will be enlarged. And not only that, you won't get the collapse with inspiration. So you're not going to get your inspiration collapse of the IVC. Inferior vena cava is going to be large and non-collapsible with inspiration. And then you get what we call an abnormal ventricule-septal bounce. You get an abnormal ventricule-septal bounce. And the reason for that is, you have fluid in the pericardial sac. It is producing increased pressures. So in diastole, when the left ventricle fills, okay, and if you take a deep breath in, when you inspire, it increases blood flow on the right side of the heart. So when you take a deep breath in, you increase the blood flow into the right ventricle. But the right ventricle cannot expand anymore because of the fluid. So what happened is the ventricular septum shift towards the left. So it shifts over to the left ventricle to accommodate the increased blood in the right ventricle in inspiration. In expiration, you're going to have increased blood flow into the left ventricle. The left ventricle cannot expand towards the pericardium because of the increased pressure. So the septum moves to the right to accommodate the increased blood flow into the left ventricle. So the septum is constantly moving back and forth, back and forth. That's what we call the abnormal septal motion. In inspiration, it's going to move to the left, and in expiration, it moves to the right. All right, so you look at the fluid, the M mode, the IVC will be large and lack of inspiratory collapse. And then you look at your mitral inflow. Look at your mitral inflow. Yes, you decrease the sweep speed. You decrease the sweep speed to about 100 millimeters per second, and you get a respiratory variation in your mitral inflow. Respiratory variation. To be specific, you get a more than 25% decrease in your ENA velocity with inspiration, and that is almost diagnostic. So with inspiration, okay, you get an increase in your ENA velocity, and then with expiration, it decreases. Okay, so it increase and then decrease, more than 25%. Now, constrictive pericarditis. So they love constrictive pericarditis on echo in any exam that includes cardiology. They love constrictive pericarditis because with constrictive pericarditis, what happens is you may have repeated pericarditis, or you may have blood or something in the pericardial sac, which cause the pericardium to become fibrotic, thick, and stone-like. And so it's like the heart is encased in a stone. The heart is encased in like a stone cavity or a stone sac. So the heart can contract, yeah, but it just cannot expand because it's like a stony case. Okay, the heart is encased in a stony, rigid sac. So again, it can contract, okay, but it just cannot expand. And that is what we call constrictive pericarditis. So you have a thickened, calcified fibrotic pericardium that forms a non-compliant shell around the heart. So it prevents the heart from expanding when blood enters, but it can contract okay. The causes, of course, infectious, TB, fungal, parasitic. A long time ago, TB was a very, very important cause, or a very common cause. Other things include chronic pericarditis. You have pericarditis for a long period of time. It can be post-viral, surgical, patients who have open heart surgery because blood gets into the pericardial sac. They can develop constrictive pericarditis. Post-myocardial infarction, that's heart attack, post-heart attack. Post-radiation therapy, chronic renal failure, chronic kidney disease, connective tissue disease such as lupus, rheumatoid, and malignancy, cancers. Patients is going to present with heart failure. So when you do clinically, patient going to give you all the features of heart failure. When they walk, they have shortness of breath. When they're lying down, they have to use multiple pillows. When you look at the legs are they have edema. When you check the abdomen, they have what we call ascites. For a for a keen physician, however, you know, these patients tend to have a lot of ascites and a lot of leg edema. So if the patient have heart failure and they come to you and they have a lot of ascites, which is fluid in the abdominal cavity, and a lot of edema, you have to think outside the box a little bit because they probably do have constrictive pericarditis, but they're going to essentially present with heart failure symptoms, ascites, hepatomegaly. The liver will be very large and tender when you palpate the liver. It will be tender. A lot of leg edema. Sometimes the leg edema comes all the way up to the thigh, and then they have this what you call Kussmaul sign. The Kussmaul sign. So what happened is, remember what we said with inspiration. With inspiration, you normally have increased blood flow to the right side of the heart. Okay, when the patient take a deep breath in, you have increased blood flow to the right side of the heart, but the ventricles cannot expand to accommodate any blood. So when you take a deep breath in, blood is trying to get into the right side of the heart, but because it's already filled, the veins in the neck gonna bulge up. So you get it's a Kussmaul sign is raised jugular venous pressure with inspiration. When we say jugular venous pressure, the jugular vein is gonna increase. So when the patient breathes in, with a normal individual, when you breathe in, you have increased blood flow to the right side of the heart, but the right side of the heart can accommodate that because it's a healthy heart. So it just expands to accommodate increased blood flow. When you have constrictive pericarditis or tamponade, you don't have that. The heart cannot expand. Okay, you're gonna have the septal bounce, but that's not enough. So the additional blood cannot get inside the ventricle. So the veins in the neck gonna bulge up because the blood have to go somewhere. So you have the Kussmaul sign, raised JVP with inspiration, pericardial knock, because when the heart in diastole, when the heart try to increase its size, it's going to knock on that stony pericardium. So you'll hear this diastolic sound, which we call a pericardial knock. The patient is going to be fatigued because they cannot, the output from the heart is going to be reduced. Heart failure patients usually are fatigued, and they'll have pleural effusion. Okay, they may have a little bit of pericardial effusion in addition to the thickening of the pericardium. When you look at your M mode, you can see pericardial thickening. 2D echo will also show some thickened pericardium. However, you have to be aware that about 20% of patients with with constrictive pericarditis have a normal pericardium. The pericardium measures normal. It's just that it's stiff. It's non-compliant. Okay, so a good 20% of them will have a normal pericardium. Remember, we talk about the septal bounce because the ventricle cannot enlarge, so the septum have to take up the slack. So the septum is going to move back and forth, back and forth. In inspiration, it's going to move to the left. In expiration, it's going to move to the right. So septal bounce. So abnormal septal motion or septal bounce. When you look at the posterior wall, you get this so-called diastolic flattening of the posterior wall. And again, respiratory variation in ventricular size. So in inspiration, the right ventricle is going to increase in size. Left ventricle is going to decrease because the septum is moving to the left. In expiration, the septum going to move to the right. So the right ventricle is going to decrease in size, and the left ventricle is going to increase in size. And then you have this dilated inferior vena cava, just like tamponade. It's huge. Echo can make the diagnosis of this constrictive pericarditis. A number of years ago, we had to take the patient to the cath lab, and we have to do all sort of stuff. You can make this diagnosis in the echo lab. Okay, this is on the M mode. You have this is the flattening of the posterior wall that we talk about. So it's a diastolic flattening. ECG is on the bottom. Diastole is from the end of the T wave to the QRS. So this flattening of the posterior wall, and you can see it again. And then you can see the septal bounce. Okay, in inspiration, it's gonna move to the left. Okay, and then expiration move to the right. So you see the septum moving from side to side. Okay, so you can have a little bit of pericardial effusion. Okay, as well as you may not have any. Okay, so this is not a muscle disease. So the patient have classic features of heart failure. They give you all the history of heart failure. You take them to the echo lab and you do your tissue Doppler imaging. Boom, the E prime is 10 centimeters per second, 12 centimeters per second. Right away, it's not heart muscle disease. Okay? So this is a huge tip-off. Once you see this, patients have classic signs of heart failure. E prime is as a matter of fact, the E prime is usually large. You can almost 90% of the time make your diagnosis constrictive pericarditis. However, you have to show that, remember, if the patient is in heart failure, the filling pressures have to be elevated. So you also have to show that your EE prime is greater than 15, suggesting that there is increased filling pressures. Okay? All right? But your E prime is going to be normal. Not only normal, we talk about an annular paradoxus. Annular paradoxus, pulsus, or annular paradoxus. And what that means, remember in the normal tissue Doppler, the lateral E prime is usually larger than the medial E prime. With annular paradoxus, it's the reverse. The medial E prime is larger than the lateral E prime. So these are things that so patient is in heart failure. You do your E prime, 10 centimeters, 90% sure it's constrictive pericarditis. EE prime greater than 15, confirming that the patient is in heart failure, 95%. And then if the patient have annular paradoxus, where the medial is larger than the lateral, 99% sure is constrictive pericarditis. So you have to be 100%. So the 100%, I'll show you how you get the 100%. So of course, when you do your mitral inflow, you get inspiratory decrease in your E. So when the patient breathes in, for the same reason as tamponade, you're going to get inspiratory decrease in your E and A velocity by more than 25%. So you can't use that because the patient may have tamponade. So you can't use that by itself because, some lung disease can give you the same type of pictures. Patients have COPD, emphysema. You can get that inspiratory decrease in your E and A velocity. So, just that by itself is not going to clinch the diagnosis. So, again, your tissue Doppler, huge. Patient is in heart failure, but the E prime is huge. Right away, it is not heart muscle disease. This patient does not have any cardiomyopathy. Okay? Most of the cause for heart failure, patients have some sort of cardiomyopathy. When you look at your IVC is dilated, much more than 2.1 centimeters. You don't get that inspiratory collapse of your IVC. So that's going to seem it's huge. Okay, this is what take it up to 100%. 100%. if you do your hepatic vein flow, and in expiration, if you get an increase in your atrial reversal with expiration, this clinches the diagnosis. You need nothing more. Okay? You remember that with your hepatic vein flow, you're going to get a systolic component, diastolic component, atrial reversal, systolic component, diastolic component, atrial reversal. But in expiration, your atrial reversal flow is going to be exaggerated, increase. This clinches the diagnosis. So patient presents with classic heart failure. They have a normal E prime, definitely not any type of your cardiomyopathy that you know about. Because cardiomyopathy means heart muscle disease, E prime is going to be low. Your EE prime is going to be more than 15, suggests that the patient is in heart failure. You get your dilated IVC. When you look at your mitral inflow, you're going to get your decrease in your ENA with inspiration. But when you look at your hepatic vein flow and you get this it's 100% constrictive pericarditis. Because with tamponade, you don't get this. Okay? Tamponade, you get this increase with inspiration. This is where you get in with expiration. So this clinches constrictive pericarditis. And that's the end of, remind me to do congenital absence of the pericardium. That's the only other thing we need to do. Congenital absence of the pericardium. But that concludes the pericardial disease lecture. And, so